Good evening, everyone. Welcome to our back pain webinar series. My name is Elise Hilskamp, and on behalf of Premier Health and Premier Health Spine Specialists, I would like to thank each of you for attending this evening. We're very happy to have you with us on this soggy April evening. Tonight we are here to discuss back pain. As you may know, back pain is a common issue for many, but you are not alone. The good news is that there are options available to help reduce your pain, increase mobility, and get you back to the activities that you love. Our physician expert, Dr. Tony Rastegar, will give a brief presentation this evening on those options. He will also answer some of your questions following his presentation. To submit a question, if you'll scroll your mouse down to the bottom of kind of the Zoom panel there, you'll see the mute button and things like that too, but you will see a Q&A button. In order to submit a question to us this evening, you will click on that Q&A button at the bottom of your screen, and you will just simply type in your question there. You can send in your questions at any time during the presentation, but we will wait to ask all of the questions until the conclusion of Dr. Rastegar's presentation. There's also a chat button on your screen, but please disregard that and send your questions specifically to that by clicking on that Q&A button. We will try to get to as many of your questions as possible tonight. Also, just so you know, this seminar will be recorded, so you will receive a link to the recording via email in the next few days, should you want to go back and reference any portion of this evening's presentation. So let's start off our evening by introducing our speaker. Dr. Tony Rastegar is a board-certified spine surgeon, and he has dedicated his life to providing a patient-tailored algorithm utilizing conservative, minimally invasive, microscopic revision or deformity correction operations based on his patient's specific needs. Dr. Rastegar's primary objective is to identify a treatment strategy that will enable his patients to return to the highest level of function possible. To guide his decision-making, Dr. Rastegar puts great emphasis on getting to know his patients to enhance a more collaborative and dynamic relationship that will enrich their experience and improve their outcome. Dr. Rastegar attended the prestigious University of Chicago Pritzker School of Medicine and completed his medical residency at Oregon Health and Science University's Department of Orthopedic Surgery. He continued his training at the Combined Neurosurgical and Orthopedic Spine Surgery Fellowship at the Cleveland Clinic. When he isn't practicing medicine, Dr. Rastegar enjoys spending time with his newborn daughter, wife, and family. He also enjoys biking, exercising, traveling, and outdoor activities. Dr. Rastegar practices in Middletown and Monroe at Premier Orthopedic Spine Center. He is also part of the Premier Health Spine team. Premier Health Spine takes the pain out of finding a back and neck specialist. With one call, you'll be connected to the right specialist for you from our team of orthopedic surgeons, neurosurgeons, pain management specialists, and physical medicine and rehabilitation specialists. So without any further ado, thank you, Dr. Rastegar, for being with us this evening, and I will turn the presentation over to you. Dr. Rastegar, take yourself off of mute.
My apologies. So Elise, thank you very much for the great introduction. It's a pleasure to join you guys tonight and talk about back pain. I know it's an issue that affects everybody, and including myself, and it's something that I feel like we have a lot of solutions for. And this presentation is an introduction or a avenue by which you guys can reach out to us and have all your questions answered. Back pain is a very large topic, and it was a very difficult, it was a challenge to try to put everything that I could possibly talk about into a small presentation, but I chose a few big issues that I commonly see in clinic, and we're going to review those shortly. But if you guys have any questions about anything related to the spine, it could be neck, back, weakness, balance issues, feel free to ask questions, and I'll be more than happy to answer your questions now or possibly at a later time. So let's get started. So basically, this is the topic tonight is back pain. and this so basically back pain is one of the most common reasons why patients see their primary care physicians. It's actually the only second to upper respiratory infections, and approximately 80% of patients in their lifetime are afflicted by back pain at any moment during the at any moment or time point. There's approximately 30% of patients that have back pain, and it is the most common reason that patients under 50 years old apply for disability. So what are the causes of back pain? So as I said earlier, there are a lot of causes, a lot of rare but serious problems can cause back pain. But the most common cause is either muscle strain, which is the most common cause, or degenerative conditions as listed here. So we're gonna go through these common causes of back pain, but I'm gonna pinpoint some red flags or important symptoms that we as physicians have to look for to make sure there's nothing serious going on. But once that's ruled out, the most common cause of the back pain are the ones listed here. So what are the risk factors of getting back pain? As we all know, obesity is one risk factor. The reason is that in this game called life, gravity is our enemy. And the larger mass your body has to carry, the more your muscles are gonna have to carry, and the more force is gonna be on your joints. And over time, your joints wear out faster, and they start becoming symptomatic. And smoking is another risk factor. Many studies have shown that because of the vasoconstriction or constriction of the blood vessels that nicotine causes, it leads to rapid arthritis and subsequently decreases healing and leads to prolonged back pain. Gender is also another risk factor. Males are typically more likely to have back pain. Genetics can play a role in how fast you acquire arthritis, and that's because of the way the collagen fibers are basically genetically changed. And lifting, heavy lifting leads to back pain, and occupations that have a lot of vibration can lead to a lot of back issues. So as I discussed earlier, as physicians, when somebody comes in to see us, we want to make sure we are not missing the big diseases, the big problem. So one of the problems is infection. So a patient with a spinal infection will present with back pain, and if that infection progresses to epidural abscess, where it leads to compression on the nerve roots and the spinal cord, that can lead to spinal cord injury or weakness, and subsequently, if missed, can lead to paralysis. So that's one thing we want to rule out. It's not very common, but if there's a risk factor, say IV drug user, a person with immunodeficiencies, those are the patients that we're going to be more keen as to looking at the possible infection being a cause of their back pain. Tumor is another thing we want to rule out. So a person who has a history of cancer, we're always more, we think about it more about them having tumor. We ask patients about having night pain, having pain that's not related to activity. And typically if they have that, they're going to be a bit more curious as to what the cause of the pain is. If somebody has trauma, we have to make sure that there is no unstable injury to the spine. So we're going to look into that further depending on the mechanism of the trauma. And then if somebody has Cotter-Quana syndrome, they can present with back pain. And this is a surgical emergency. And typically patients present with bowel bladder dysfunction and also lower extremity pain and weakness. So these are the red flags I want to rule out. Once these are ruled out, then we think about the common causes. So when we think about the common causes, sorry about this slide being really busy, we can classify back pain many different ways, but one way is to classify it as axial back pain, which is the most common, seen in 92% of patients with back pain. And we can think of neurogenic back pain. So that's where back pain is secondary to nerve compression. So an axial back pain can be divided into its own subclasses. musculogenic, discogenic, mechanical pain, or SI joint pain. And as you can see here, axial back pain is more mechanical in nature. It is some mechanical imperfection in the spine leading to back pain. And neurogenic, as the nerve implies, is where you have some nerve compression that leads to back pain. Referred pain actually refers to an axial pain being referred down to your legs, and that can happen because of the muscle spasm or kind of that compensation that your body undertakes to deal with the back pain you're experiencing. So now, axial back pain. So this is, as again I said previously, is diagnosis of exclusion, meaning that we have to rule out all the serious issues, and typically that's easily ruled out by asking about various constitutional symptoms, fevers, chills, or nocturnal or night pain. And once that's ruled out, we can divide axial back pain into its length of presentation. So it could be acute, less than a month. It could be subacute, 1 to 3 months, or it could be chronic, over 3 months. And depending on which category the patient fits into, we treat them differently. So again, axial back pain, it's 85% of the low back pain that is seen by the primary care physicians, and it rapidly, in majority of patients, it rapidly improves within the first month. And however, once you have axial back pain, your recurrence rate is approximately 33%. And about 10% of patients end up having chronic low back pain. And 90% of patients have resolution of their symptoms within 1 year. And so what are, as I said earlier, the cause of axial back pain is usually anatomical structure that has sustained some injury or abnormal stress. And what are these anatomical structures? As you can see in this picture here, there are basically, the main area is a disc. This is an actual view of the spine. It's as if somebody is laying on their belly and somebody cut them in the middle and is looking at their spine. So this would be their front, this would be their back, this is the skin of their back, and these are the muscles in the back, and this is the disc in the front, and these are the neural structures right here. So the disc can play a role in back pain. And as you can see here in this image, this round structure, this is how you want the disc to look like. But if you have a little bump like this is an annulus rupture right here. And once you get an annulus rupture, it can lead to some back pain, and because the annulus, or the outer covering of the disc, is where you have all the innervation of the disc. And then in this picture, they also show that the nerve, because of that disc bulge, there's a nerve compression, which can lead to nerve pain. But you can have the fascia be the cause of the pain. It could be a muscle strain that can cause the pain. And muscle strain is the most common cause, or it could be the facet joint. So these are the joints between the two vertebral bodies. So facet joints are basically like handshakes. So the hand of the guy on the top. So this is, if this was L4-5 disc space, this would be the hand of L4. This would be the hand of L5. And that handshake is called a facet joint. And sometimes that handshake can be a cause of back pain. And sometimes we can have the SI joint be the cause of back pain. And that's typically back pain that's in the lower back, and usually on one side, and it's worse with standing, sitting, and we do certain exams to confirm that diagnosis. So what do we do when we have patients with back pain? So the number one thing you want to do when you have back pain is to first rule out the important diseases. Once that's ruled out, we want to start gentle exercises. So we want to make sure that your body doesn't get too stiff, and we want to make sure that you don't start acquiring maladaptation or compensating the wrong way, because these compensations can lead to further problem down the road. So they can lead to secondary pain sources that were the result of the initial injury. So, and a lot of times that primary injury can heal, but the secondary compensation pain can lead to bigger issues down the road. So if the patient comes in within an acute, so less than a month of back pain, we say, you know what, we got to try, and there's no red flag signs, we say we got to try conservative care. So that includes, and we don't want to get x-rays at that point. But if the patient comes in after a month of back pain or they have red flag signs, then we would try to get radiographs, and that could be x-rays or MRIs. And it is important to note that imaging will show us imperfection. As we live, we acquire imperfections in our body. It's just like getting gray hair. We all get it. And so just seeing imperfection on the x-ray doesn't mean that that's the cause of the back pain. And for example, in this image, this patient has degenerative changes of the lumbar spine. And also they have L4-5 spondylolisthesis, or shifting of the vertebral body. So what that is if you follow the back of these vertebral bodies, they're all in line. But when you come here, there's a small step off, and that is a spondylolisthesis. And this is secondary to arthritis. In this patient, most likely it's arthritis, degenerative spondylolisthesis. That can sometimes lead to back pain, but not all the time. And then we can also get MRIs to look at the spine in more detail. And then the treatment is basically lifestyle changes initially: diet, exercise, weight control, stopping the smoking, doing smoking cessation, physical therapy, and trying to work on getting the pain under control, but again, trying to resume activities and gradually increasing that activity level. The way I describe it to my patient, if this is your pain threshold right here, you want to go at about just below that pain threshold. You don't want to aggravate it, because if you aggravate the back pain, the threshold is going to drop. You want to stimulate, but not aggravate. As you stimulate and get stronger, the threshold goes up and you keep going up with it. But if you don't do anything, your body gets weaker and that threshold drops. So the key is to stimulate, but not aggravate. And then say if the patient does all that and doesn't work out, then we want to take it to the next level, do further imaging, including MRI, and then consider diagnostic injections. So we pick one of the imperfections on the MRI and we try to inject it and see if that could be the source. And if the injections don't help, various other pain interventions don't help, then surgery could be an option that can be discussed. So now I'm going to go into lumbar radiculopathy. I think I'm taking too much time, but I'm going to speed up a little bit, but feel free to ask questions as needed. So this is lumbar radiculopathy. So once axial back pain that's the most common cause of back pain. The next most common cause is lumbar radiculopathy, and this is commonly known as sciatica. It is most commonly seen at L4-5, L5S1. So the bottom two levels of your lumbar spine, in 90% of the time, and most often it's related to disc herniation. And as you can see in this image, these nerves are basically getting, so this is a normal disc here, but this one has a bulge and is basically pushing on this nerve, and that can lead to lumbar radiculopathy. And typically that radiculopathy is mainly secondary to inflammation and also some mechanical compression. And this is where sometimes oral steroids can be really helpful. So the lumbar disc herniations, they peak around fourth to fifth decade. And it's approximately seen in 10% of the population during their lifetime. It's more common again in males, and it basically results from torsional strain. So a lot of twisting or a lot of bouncing and vibration can lead to degeneration of the disc. And as the disc becomes degenerated, the outer covering or the annulus can rupture. And once the annulus or the outer covering ruptures, then you can get the nucleus pulposus, or the jelly-like stuff in the middle that can squirt out, and that can compress the nerve and also lead to significant inflammatory response that can really aggravate the nerve. And a good analogy is, imagine this is somebody pokes you with a finger that has pepper on it. So that inflammatory response is like pepper touching the nerve, and sometimes it can really be painful, and it's usually typically really painful. And steroids can help cool down that inflammatory process and decrease the inflammatory irritation. And again, 95% of these happen at L4-5, L5S1, the bottom two levels. And the prognosis is very good with disc herniation. Approximately 90% improve within 3 months. And the size of disc herniation typically decreases over time. And a sequestered fragment, or a fragment that has extruded out completely from the disc, is actually more likely to resorb over time, unlike a contained fragment. And so patients present with so typically the way patients describe their pain is they would come in and say, I had pain for about a short period, a week or two, back pain. And then all of a sudden the back pain went away and I had this severe leg pain. And this is very common because as the annulus was getting irritated and was about to rupture, there was a lot of stress on the annulus where there's a lot of nerve endings, and that's where they felt the back pain. But once the annulus ruptures, then that annulus is no longer under stress, so the back pain goes away, but then you get the compressive and the irritation that happens to the nerve, and that is typically presented as leg pain. So that could be, so basically the leg pain goes in a distribution that the nerve covers. So every nerve covers a zip code, that's what I call it, or a dermatome in your body. And it's typically a very defined, narrow band of pain or numbness that we can see. And the pain is usually worse with sitting, coughing, or sneezing, anything that increases your intra-abdominal pressure, because then that puts increased pressure on the disc and leads to more disc fragments coming out. And in severe cases, I've had a couple of patients who had large disc fragments that led to cauda equina, where the disc was so large that compressed all the nerves in the cauda equina, which is the bottom part of your spine and the lumbar spine, and they had bowel bladder dysfunction and needed immediate surgery. And so typically patients present with pain in the distribution of the nerve that's getting compressed. So L4 would present with a medial leg pain, L5 lateral leg dorsal foot, and S1 posterior calf to the bottom of the foot. And then and each nerve has its own distinct motor function. So a patient with severe L4 weakness would have decreased dorsiflexion or bringing up of their ankle. A patient with L5 nerve injury would have the weakness in their toe extension. And a patient with S1 injury would have plantar flexion weakness, or pushing their foot down, or pushing on the gas pedal. And these are the sensations. And this picture kind of depicts the dermatome of different nerves. So different colors are different nerve distributions. And there are reflexes that we also check for each nerve, but L5 doesn't have a reflex. So radiographs, again, we want to try conservative care. If patients have failed that, we do x-rays. And then MRI is also for disc herniation as a modality of choice. It gives us a good understanding of what the disc looks like. And for example, in this image, you can see a massive disc herniation that has led to significant canal compromise. This is a side MRI. These are the vertebral bodies. The belly would be here, skin of the back would be here. Nerves are these gray structures, and the white is the space around them. And this disc has taken all the white out here. And this is an actual view. We can see that there's no white, and this is a very large disc fragment. And this table here shows us they've done studies where they have done MRIs on asymptomatic patients that are normal, and they have seen a lot of imperfections on their MRI, as I discussed earlier. And I want you guys to know this, just because patients come to see us, they read their MRI report, and they come in very scared. But in reality, those imperfections are normal, and you shouldn't worry about it. Treatments, non-operative, so physical therapy, anti-inflammatory are the first-line treatments. 90% improve without surgery. We do bed rest followed by activity as tolerated. And bed rest, you want to keep it as short as possible, so less than a couple of days. Then NSAIDs, muscle relaxants, tapers, steroids are good. Then we can do physical therapy, and traction and chiropractic manipulation can be tried as well. But the key is to do McKenzie exercises have shown to help, and these are basically extension exercises that can help with decreasing the disc size. But that's not always helpful either. And then so if that doesn't work, then we can try injections, and we can do selective nerve root steroid injections, or transforaminal epidural steroid injections, or we can do epidural steroid injections. It's just how. This is, for example, an injection, a needle being put next to a nerve, and then the medication is injected along the nerve. So you can see the nerve here, and that should cool the nerve down. And then it leads about to 50% of the patients can improve with the injection. However, if they fail, then the next step is operative treatment. And the operation for this is microdiscectomy. It can be done minimally invasive through incision less than 2 centimeters. As you can see here, less than the size of your thumb. Through a tube, you can go down to your spine, take out the disc, and you go home the same day. And the next topic I want to discuss is lumbar stenosis. And stenosis just means tightness. Again, nerves like space. So once you suffocate them or put pressure on them, they start getting mad and they become painful. So incidence, lumbar stenosis is very common. It's seen in patients usually over age of 65. And it's seen about 20 to 25% of patients at that age, above 65. It's slightly more common in males. And in some cases, if a person has congenital stenosis, we can see it at an earlier age, at around 30 years old. And simply what that means is, imagine the canal of your spine is the home that your nerves are born into. If you were born into a larger canal, like a mansion, as we age, the walls come in, so you won't feel it as fast. But if you have a smaller canal or studio, if you're born in a studio, as the walls come in, you can get crushed faster. So a person with congenital stenosis, their nerves were born into a studio, whereas a person with larger canal had a bigger size home that they were born into. Hopefully that helps make it more understandable. And then, so typically 91% of the time, stenosis happens at L4-5, and it's usually second to degenerative changes or arthritis. And it leads to mechanical compression of the nerves, which leads to microvascular permeability issues and leg pain. And typically these patients present with a gradual onset of worsening back pain that leads to posterior buttock pain that goes down to the back of the thigh. And this is the classic description is the pain is worse when I stand and when I walk, but as soon as the patient bends forward, the pain goes away. So one of the key questions I ask patients is, when you go shopping, do you lean on the shopping cart, and does that help you? And if they say yes, that's almost always lumbar stenosis. It's called the shopping cart sign. And so that's lumbar stenosis. Typically imaging same. We do some radiographs. It doesn't really show much, just shows degenerative changes such as degenerative disc disease or spondylolisthesis, which is that slipping of the spine. But MRI is a diagnosis of choice. And here in this patient, we can see a side view, a sagittal MRI. Again, you have degenerative changes throughout the spine, but at this level, we see that spondylolisthesis, or the shifting of the vertebral body over L4 over L5. That leads to stenosis. So up here, we have a lot of white around the gray. That's good. We come down here and the gray has no more white around it. The white is the fluid that the nerves are swimming in. So here, imagine a fish that's just getting squeezed. And that's, your nerves are basically like a fish swimming in a sack of fluid called the dura. And here it's just getting squeezed, and they don't like that. So, and we have to be mindful that, again, that there's a lot of imperfection we see on the MRI. That's not always the cause of patient's pain. This is why I tell every patient, your spine is like a puzzle, and my job is to solve your puzzle, and we're gonna do it piece by piece. And typically patients on exam, they have decreased curvature of their spine. They typically lean forward, so their spine becomes flatter. And they walk a little bit bent forward. And they do this because by bending forward, you increase the volume of your canal by, as you bend forward, these ligaments in the back, these black structures in the back can become tight, and they can open up just a little bit more space for your nerves, and that can be enough to give them some relief. And in some cases, patients can have some weakness. However, the natural history of this is that 70% have consistent symptoms with no change, 15% get better, 15% get worse. And we have to always be mindful that about 5 to 15% of patients who present with lumbar stenosis can also have cervical stenosis. And cervical stenosis is more of a concern because up in your cervical spine is where the spinal cord is. And while the nerve roots down in your lower lumbar spine are more tolerant of compression, the spinal cord is not. So once you have cervical stenosis, that's more of an urgent issue that might need more urgent attention. So what are the treatments? So the treatment for this is initially non-operative. So we do oral medications, physical therapy, and possibly steroid injections, NSAIDs, weight loss. And then if all of those fail, then we can do a minimally invasive decompression. Then this is, you can see in this image, where we can go in from one side. Again, same idea as discectomy, you put a tube down and basically decompress the spine. So we come in from one side, and this is the initial starting point, and this is where we end up. So you see that here the nerves were getting compressed, that ligamentum flavum, the yellow is the ligamentum flavum. It was getting really compressive on the nerves. And then here we took it all out and it's wide open. The nerve is wide open. So here, this is again, just to orient you, this is the back, this is the front. We're looking at the disc and the canal right here. So, and then in some cases, if patients have instability, if they have a spondylolisthesis in the setting of lumbar stenosis and they're unstable, then we might have to decompress and fuse them. Because if we don't do that, that instability gets worse. So that's lumbar stenosis. The next topic I'm going to cover that we commonly see is vertebral compression fractures. And these are fragility fractures, meaning that these are secondary to the fact that the bone is too soft to tolerate daily activity. So a simple fall or just simple twist can lead to a fracture, a compression fracture. It is the most common fragility fracture in the US, and we see approximately there's 700,000 cases in the US. We see 25% of patients at over 70 have it, 50% over the age of 80. As we age, our bones get softer, so that makes sense that the rate of compression fractures go up. And then the biggest risk factor for compression fracture is having had compression fractures before. And being postmenopausal woman, you're at a higher risk of having osteoporosis and subsequently a higher risk of having compression fractures. And so patients typically present with severe pain. In 25% of patients that come to the hospital, they come in because of pain. Sometimes actually patients can never notice they had compression fracture. We've had a lot of patients who come in with chronic compression fractures. We do imaging, they have a new one, but they've had multiple other ones that they had no idea they had. So sometimes it could not be as painful. And so physical exam, so when they come in, we can kind of see that they have some tenderness in certain areas. And in rare cases, they could have spinal cord injury if there's severe stenosis or a severe basic compression of the nerves, if the bone is really compressed. And in that case, it could be called a burst fracture, but in some cases, they could have severe kyphosis where the spine just falls forward and that can put tension on the spinal cord and lead to issues down the road. And in some cases, we can get nerve root compression, but those are rare. Typically, it's back pain that's commonly seen. And the imaging of choice for them, we typically get x-rays. And sometimes in the chest area, the chest x-ray may not be as ideal. You still can see it, but we might see multiple compression fractures. And at that point, we have to find out which one is new and which one is old. And that's where MRI is key. MRI really helps us find out which one is new and which one is old. And if the pain is really severe, we can treat that worst level or that new fracture level. So again, what the treatment is, initially, we want to treat non-operatively with observation, bracing, and medical management. And then if those fail, the next option is to do cement augmentation in the form of typically kyphoplasty, which can help normalize the height of the vertebral body and minimize kyphosis. And this is typically an outpatient procedure. A patient typically have immediate relief of pain and they go home the same day. So while I could go on all day talking about back pain, I decided to stop at this point, and we're going to open it up to questions.
Okay, thank you, Dr. Rastegar. If anybody has any questions, we've already got several that have come in, but just want to remind everyone to go to the bottom of your screen and click on the Q&A button and feel free to type your questions in there. All right, so we will get started. We have a question. Is there anything that I can do about scoliosis?
Yes, so scoliosis, the best thing you can do is to stay flexible. You want to do you want to keep your muscles strong and work on flexibility. So doing yoga, doing Pilates is really helpful to try to minimize discomfort. And it depends on how bad also your scoliosis is. And sometimes at the initial treatment is to just get your back strong and keep a good posture, and just like you floss every day for your teeth, you want to do that everyday yoga. You want to stay ahead of the pain. You don't want to wait for the pain to come and play catch up. So daily yoga, daily physical therapy or core strengthening exercises should be number one. And then if that doesn't help, then we can do radiographic evaluation and see how bad your curvature is. And if there is a structural issue that we can address to fix your problem and take care of your pain. Hopefully that answered your question.
Okay, thank you. Next question. Not sure what to do. I have pain on the right side of the back of my neck, and it hurts specifically when I turn my head. Okay,
so that depends on, that's most likely when the pain is only on one side, that's muscular most often. Okay, and I would assume the pain gets better when you're not holding your head up. So when you're laying flat in a bed, the pain should be better. And when you're rotating, you're basically using the muscle, and the muscle is strained. I'm not sure how long you've had it for, but if it's an acute strain, it usually gets better. And I would work on, again, flexibility and reteaching your muscles how to function normally despite this pain. So your muscles, they once they're painful, they become guarded. And you want to tell them that life is okay. I know you're painful. This is going to get better, but you want to get them out of the survival mode and let them thrive. And the way you do that is by doing gradual range of motion and strengthening exercises of your neck. And if that fails to improve after about 4 weeks, you come and see a physician, and we can do further workup and see if there's any other etiologies that could explain your symptom. But 90% of the time, it's just your muscle.
Next question, is there a relationship between abdominal muscle strength and back issues?
Exactly, that's a fantastic question. Yes, it is. So your core, the way I describe it is like a soda can. So the stronger the core is, it's like a full soda can. You can't easily bend it. But the weaker the core is, it's like an empty soda can that you can easily bend. So when the core is really weak, there's a lot of stress on the back. The back muscles have to do a lot of work to hold you up. So that's why we gotta get the core needs to be stronger to minimize the stress on your joints and your muscles in the back. So yes, abdominal muscle strength is key to a healthy back. Yes.
Okay. What treatment would be recommended for disc degenerative disease that has been causing pain for over 6 months?
So a great question. And I would say the pain, again, we want to work on core strengthening, because once you get the core stronger, you help distract the spine. When the core is weak, you're basically falling into this, forward posture that really puts a lot of pressure on your disc. But if you keep an extended, an upright posture, you actually reduce the stress on the disc. If that doesn't get better over time, if it's getting worse over time, then we can look into it further. If it's improving, but improving slowly, that means you're on the right track. If it's staying constant, I would say come and see us, and we can look into it in more detail and see if there's anything we can do. If nothing helps, and we can really localize or paint to that disc, then fusion can be a good choice. But where we can just, because if that disc is really damaged, fusion or disc arthroplasty can be a good option for treatment. But disc arthroplasty has a very narrow indication. That means it doesn't apply to everybody. You almost have to have a perfect spine, except one bad disc, to qualify for disc arthroplasty. But yeah, if the pain is really bad, feel free to come and see us, and we can look into it further.
We have several questions coming in, so I'm going to kind of consolidate them because they're basically all the same. What exercises do you recommend to strengthen the lower back? And then there was kind of a sub question about the McKinsey exercise that you mentioned. What exactly is that?
So that's basically, so again, you want to work on getting your core stronger. So Pilates is a good thing to do to get your core stronger. You want to work on your abdominal muscle strength. You want to work on your extensor, so doing a lot of extension exercises, and really being able to keep your body flexible. So flexibility and strengthening go together. You know, if when you have a painful body part, your body goes into a constriction survival mode. You want to get it out of that, because once it's constricted, it actually worsens distress induced on those damaged joints. So strength and flexibility is the key.
Okay. What treatments are available for SI joint dysfunction?
That's a good question. Again, so SI belt. So if you go on Amazon, it's only about $30. You can get SI. Actually, my wife had SI joint pain, and we used the SI belt for a while. She couldn't walk without the SI belt. So, and that was when she was pregnant. And this is very common during pregnancy where the ligaments become a little bit lax. But for her, SI belt did magic. And then then physical therapy to strengthen the muscles around the SI joint. If we try all of those and they all fail, we can try injection as another alternative. And then if that fails, then SI fusion becomes the next option.
Another SI question, how many SI joint injections can you get? I had one, it gave me relief for about 30 days and now the pain is back again.
You know, you can, so the rough guideline is about 3 injections a year. But in reality, if you got it 30 days ago, you can easily get another one, go back and get another one. But you want to keep it to less than 3 a year. That's the general guideline, but I've had patients that have had more. The idea is that steroids can lead to some mild damage to the surrounding tissue, but if the pain is really bad, the benefit far outweighs the risk of steroids.
For treatment, what is your experience with hydrotherapy?
I'm not really experienced with hydrotherapy. I have to admit that, but I have no experience with that.
What can I do for neck clicks?
Good question. So neck clicks, as long as they're not painful, they are not worrisome. Again, that is partly from the arthritis that you have in the neck. You're lucky that you don't have pain from it. Again, to reduce the joints, the stress on the joint, you want to work on flexibility and strengthening of the neck muscles. So once you get the muscles stronger and get the neck flexible, that should reduce the stress on the neck, on the joints, and you should have less clicking.
Can arthritis in the lower back be eliminated forever?
No. Arthritis, we can live with it. You can't get rid of it. We have to learn how to live with it. It is just a normal part of life. It's just like getting gray hair. It comes as we age. And we just have to learn, and arthritis by itself is not painful. The way I describe arthritis, imagine your joints are like 2 icy surfaces. As we age, the ice melts and you're left with gravel surfaces. So if the gravel surfaces don't have any other support, there's no muscle support to hold the joint more stable, they're going to keep, rubbing each other really intensely. It's going to cause a lot of pain. But if the muscles get stronger, you become flexible. Instead of rubbing, they glide. And that helps with the back pain. So the key is to get the secondary stabilizers, your muscles, to come in and help out. There are patients with severe arthritis and no pain. That's because they have learned, their muscles have come in and they have compensated for their arthritis.
We have several questions around chiropractic care and how it fits into back pain treatment. Should that be a first line of defense when pain begins occurring?
Yes, yeah. So the way I look at chiropractic treatment, it's a passive modality. So basically, the person who's doing all the work is your chiropractor, which is really good. It's like they're massaging your joints. But the problem with a passive treatment is that it doesn't last for a long time. The active treatment, like physical therapy, gives you slower relief, but a more long-term relief. Whereas chiropractic treatment gives you a shorter, an acute relief, but it doesn't last for a long time because your body keeps reverting back to that imperfect posture. So you want to reteach the body so you can do chiropractic treatment, but I would do physical therapy at the same time. So chiropractic treatment can give you relief now, and physical therapy can retrain your body to keep a normal posture and strengthen the muscles, the supporting structures that can relieve the back pain forever, for a long period.
I have a couple questions that are similar around people who are waking up with lower back pain when they're first getting out of bed, particularly on their right side. It hurts for the beginning, and then as the day goes on, it's fine and they can resume their activities. Is that normal, or what does that mean?
That is arthritis pain. So again, and just taking that analogy of gravel surfaces, your body actually does something to prevent the friction, and that's synovial fluid. It's like oil spray. It's this lubricant that your body secretes in the joints to make the surface slippery. And that only happens with motion. So when you're laying flat all night, the surfaces dry out. So you have dry gravels that rub against each other. So that the friction is really much higher. So that leads to a lot of pain. Once you start moving and you loosen things up, there's less friction. So that's arthritis pain. So again, the key for that is to do flexibility exercises, back strengthening, to take your joints from rubbing to gliding. And so that's basically a good example of that synovial fluid is a patient with knee arthritis that gets knee swelling. That's their body trying to secrete a lot of fluid to lubricate the joints. Yeah.
Okay. The next question, what would cause pain and swelling of the hip area?
Okay, that's good question. So the key is what part of the hip. So hip, the joint itself, it's in such a deep socket that you don't really see the swelling of the joint itself. It all depends on where the swelling is and what causes the swelling. If it's, typically we don't see swelling just out of, around the hip, or it's not, because there's so much tissue around the hip, so it's very hard to see significant swelling. But one of the biggest things we can see around the hip, if the pain is on the lateral aspect of your hip or outside of your hip, that could be bursitis or inflammation of the bursa. If sometimes not that you have it, but if there's redness with that swelling, could be infection, or it could be some we would have to say it could be a lot of different things. But most often, if the swelling is activity related or there are other constitutional symptoms, it is good to come and see somebody so we can take a look at it. But it's not typical for us to see swelling around the knee from arthritis. Around the hip. We usually see it in the knee because the knee is a more superficial joint. So the swelling of the joint is more visible, whereas the hip joint is so deep in the socket of the hip that there's a lot of tissue around it. So arthritis swelling should not show up on the surface.
The next question is, if I've had epidurals done previously, can these be redone?
Yes, if they were helpful, they can be redone. Yes. Usually with epidural steroids, they become less and less effective the more you get them.
Okay, a few more questions coming in. Does walking help arthritis back pain?
It does. Walking, any form of exercise. So when you have arthritis, your enemy is gravity. is trying to pull the joints down and make them rub against each other. And your friends in this game are your muscles. So anything you can do to get because your muscles are what keeps you up. So as the muscles get stronger, you can help distract the joints. So instead of rubbing, they glide. So walking is a perfect exercise. That's the best posture. So sitting is actually, we do a lot of sitting on a daily basis, but that's actually not a good posture for our back. But walking is a good posture. That's why having a standing table is really good for your back.
Okay, next question. I have issues with C4, 5, and 6, and it seems to affect my right trapezius area. Is this referred pain?
Good, it is. Most likely it is. It is, because your trapezius all runs from your occiput down to the thoracic region, bottom of your thoracic region. And whenever you have a joint that is damaged or irritated, your body wants to help, wants to jump in and do something. Usually it doesn't do something right. And a good analogy is, imagine motion is like a dance routine. So you have 50 dancers in this team. If one gets injured, the way your body responds is the other 49 want to come and help that one guy, but the whole routine falls off. So this is why physical therapy, we train them to say, you know what, we still have 49 people. Let's divide the job of that one guy amongst the other 49 in an organized fashion so we can still dance. And this is where, yeah, so it can be referred because of the compensation that your body is doing.
Next question. I have accentuated thoracic kyphosis, and is anything able to be done?
Yes, so it depends. You probably have Sherman's kyphosis. It depends on what your symptoms are. We can always, typically, you know, we want to keep your back muscles strong, but if the symptoms are really, really bad, then we can try to correct the kyphosis by surgery, where we can basically realign your back and bring you into more extension.
This gentleman is 75 years old and has lower back pain. He plays golf several times a week. Can the torso movement involved with golf cause the pain? And if so, what should I do to help alleviate the pain?
Yeah, it can. So that torsional force, that rotation that you do is actually really, it aggravates your disc. So our bodies are good. We're designed for compressive load, not torsional load. Your disc, your bones, torsion is the weakest mode of strength for our bones and our tissue. So that torsional rotation that you do aggravates the disc. So I would say to alleviate it, I would either alter your swing, or I would try to compensate by keeping your by getting all the secondary helpers as strong as possible. So getting the core stronger, keeping a good posture, staying flexible. But again, that torsional load on the spine is gonna speed up the arthritic changes of your back. So, but you know, you want to live your life. You don't want to be. You got to enjoy your life. So you can't just always play it safe. So enjoy what you're doing, but try to work on the secondary stabilizers, your core muscle, your back muscles, get them stronger, and try to stay as flexible as possible. And before taking a huge swing, try to go through that range of motion gently to get your back ready for it.
The next question is, do you have any opinion about acupuncture for pain relief?
Yeah, so scientifically, we don't have a lot of supportive data, but I've heard some patients who have had great results from it. So I think it is very patient specific. I've had some patients that could not tolerate it, but I think it is something that you can definitely give a try out and see if it works for you. There is little harm to it, so I would definitely give it a try. And sometimes it helps you, sometimes it may not. But unfortunately, we don't have a scientific a protocol by which we can prescribe acupuncture.
Couple people are writing and saying they wake up at night with a lot of pain in their lower back. One is in the sacral area. The other says it sometimes radiates down my leg to my knee. What causes this and why does this happen?
So pain at night, when we hear that initially as physicians, we always kind of think about inflammatory issues that could be causing the pain. Typically, arthritis pain should get worse with activity. And so if you're having shooting pain down your leg, it could be some a form of nerve compression, but you're describing a dermatome in front of the thigh. It could be your L3 nerve, or it could be possibly a muscle spasm. I'm not sure if you've recently changed your bed. Maybe that could lead to it. But if it's been going on for a long time, definitely come in and we can see you and make sure there's nothing serious. There's no other explanation except just normal arthritis or muscle related pain. Because night pain, whenever we hear it, we just want to make sure we're not missing something.
My gym has an inversion device. Do you recommend its use?
Yeah, so basically inversion device are basically trying to turn gravity upside down. So when I said gravity is our enemy when we have arthritis because it's pulling us down. So when you go into an inversion table, you're actually using gravity to distract. So it can actually help for a short period, give you relief at that moment, but typically the relief doesn't last for a long time. But it can give you relief for the moment that you're doing it. Because as soon as you turn around and you stand upright, gravity does its thing. It just pulls you down. And you got to make sure that from a medical standpoint, you don't have any aneurysms in your head or any other medical problems that could be a contraindication to inversion table. Because when you invert, when you go on an inversion table, the blood flow to your brain increases. And in some patients, that can lead to intracranial bleed or a rupture of a blood vessel.
A couple questions around nutrition and supplements. What are your recommendations around that to prevent back pain as you age?
Yeah, I think you want to focus on having a healthy diet, both from a being in shape standpoint and minimizing obesity, and also from giving the body the right nutrition to heal itself from the daily wear and tear. So you want to have a diet that's high in antioxidants to deal with the daily inflammation. So keep a healthy diet with high antioxidants, and that should be really beneficial.
Does massage therapy help back pain? And this particular person, it seems to aggravate their pain, as does the twisting motion in Pilates, but.
Yeah. So I think massage, again, it's a passive treatment. The masseuse is doing all the work, and you are, your muscles are not doing any work, and so if it doesn't help you, I wouldn't do it because there's no long-term benefit from it. The only benefit is short-term. If you're not getting short-term benefit, then I wouldn't see a reason why do it. And if putty makes the pain worse, again, think about that threshold that we talked about. If this is your pain threshold, that means you got to go a lower intensity exercise. So I personally do yoga all the time myself. If I don't do it for a long time, I start getting back pain. So, and I can't do the fancy poses. I typically do the beginner's yoga, and that's sufficient for me. And if I try to push it too much, it can really lead to, aggravation. So you want to, again, be mindful of that threshold. Anything that causes aggravation, don't do it. Stimulate, but don't aggravate. You don't want to do little either, because as you do little, the muscles get weaker and the threshold drops. So you got to kind of calibrate that yourself.
Do you recommend nerve killing in the back?
Good question. So that's referring to radio frequency ablation. And basically that, yeah, I would say if the way they do it is they do a diagnostic medial branch block beforehand to confirm that this is the target. And if that target works, yeah, so you can definitely burn these branches that are just like weeds that come out of your main nerves, and they innervate the facet joint, and they basically go and burn these nerves, but just like weeds, they grow back. But if it helps you, I would do it for sure. But I would do that and know that that's giving you a temporary relief. The key is to do that and then get the back strong.
So I know it's 7 o'clock. There's 3 more questions. If people want to stick around, you're welcome to, but just 3 more questions and then we'll call it a night. So what causes achy hips after lots of driving, particularly if I have done a lot of walking that day? And walking sometimes makes my lower back sore and I'm only in my 30s.
Yeah, so that could be possibly from arthritis. Yeah, that could be either hip arthritis or back arthritis that leads to pain.
My only pain is in the left buttock, and it has lasted for the last 2 years. Sometimes I have muscle spasms. I exercise, I've done steroid injections. Nothing is working. How should I seek additional help?
So if it's purely localized to your buttock area, I would say we have to identify what the source is. It could be many things. It could be your SI joint. It could be basically inflammation of the hamstring insertion. It could be maybe muscle strain that never healed. So it would be a good idea if you've had it for 2 years to come in and see us, and we can do further evaluation to see if we can find a reason why you have the buttock pain.
I was diagnosed with stenosis and have been exercising for 3 years. I have periods where my feet are slightly numb in my big toe area or the pads of my feet. I'm concerned that I'm pinching a nerve.
Yeah, so stenosis by definition means that you have a tight space around the nerve and the nerves are getting pinched. So if your symptoms are getting worse over time, which is the common scenario, then it might, I would consider maybe getting further evaluation to see how bad the stenosis is. But as long as you don't have any weakness or sudden change in your neurologic status, then it's not an emergent issue. But if it's limiting your quality of life, typically the treatment for it is very simple. And even if you need surgery, if it's a decompression alone, it's an outpatient procedure. So if it's really limiting your quality of life, the treatment should relatively be simple for this.
Okay, I lied. There's 2 more questions that came through, so we'll let them through. So last 2 questions. What about the use of a TENS unit for pain management?
Great. I think using a TENS unit is always a good idea. 1, it's not that expensive. 2, it works well for some people, and I think I definitely highly recommend a TENS unit for back pain. And try it, see if it works for you. Again, Amazon sells it. And then if you don't like it, then, they have a good return policy.
Okay, our final question this evening. Does glucosamine and chondroitin help the joints? I'm sorry if I mispronounced that.
No. So that's a fantastic question. And it has shown to maybe help with pain, but it from a kind of thought process standpoint, it doesn't make sense that it's going to help your joint. Why? Because it has to go through your digestive tract. It's going to be broken down to its components, and then it's going to be absorbed as its components. It's not going to be absorbed at its full molecule, and the body can't. It's not going to help your cartilage regenerate, but it can help with the pain, if that makes sense. So it's not going to make your joints newer or improve their anatomical imperfections, but it can make you feel better. So if you find it useful, use it. But it's not helpful in everybody.
Okay, well, lots of great questions this evening. Thank you, Dr. Rastegar, for your informative presentation. We appreciate your time and expertise. Thank you all so much for joining us this evening. I hope you found the information that we shared tonight useful. We feel very privileged to be with you tonight and hope that you consider us for any healthcare needs that you may have. If you'd like to learn more about Dr. Rastegar or his practice, Premier Orthopedic Spine Center, you can visit premierorthospinecenter.com. More information about Dr. Rastegar can also be found on his bio that was sent along with the information to access tonight's event. Should you have additional questions or would like to make an appointment, his office phone number is on both the practice website and on his bio. Last but not least, as a reminder, this seminar was recorded. We will email you a link to the recording should you want to go back and listen to some or all of this great content again. And as soon as it is available, we will share the link to access the recording, probably early next week. Along with the recording, we will also send you a link for a short survey on tonight's program. We value your feedback, and we would really appreciate if you could take a few minutes to share your thoughts, so that it can kind of help us shape any future webinars that we may continue to do. So with that, we wish all of you a good evening, and thank you so much again for joining us.
Thanks, everybody. It was my pleasure talking with you guys, and feel free to reach out to us anytime and let us know how we can help you.